Hey everyone, welcome to the Psyched to Practice podcast, your one-stop for practical and useful clinical information, masterful insight from experts in the field, and a guide to daily living. I'm your host, Ray Christner, and with me as always,
Paul Wagner.
And today, Paul, we're kind of doing maybe the clinical take on an earlier episode that we did for Living Psych about adjustment.
Yeah, and it was one that I actually, as we were in the process of recording, it just felt like, there's something more. And, we're talking about these life stressors and recognizing them and talking about how to help support them. But the clinical side, it sparked some conversations between you and I, just like just how there aren't trainings, there isn't a ton of research out there really focusing on adjustment disorder, which is maybe in some ways why we get it so mixed up, or, that there's so much confusion surrounding it.
Yeah. I mean, I think we probably, it's easy to say that probably the majority of people that come in for treatment, come in for an adjustment issue to start with,
Fair point.
So it's then what do we do with that? And, how do we make sure it's not something more or even something less, I guess, in some cases, or maybe it's not even a disorder at all at this point.
Yeah.
It's an interesting topic that we don't talk a lot about. So I think it was great. It was just kind of fun to do. So I'm curious, what is your takeaway this week?
Something that was said earlier on, and I think we just kept coming back to it again and again in the episode. But the idea of don't stop when we get to the easy answer, because you just said it. Everyone who comes in has some form of adjustment that's occurring. But if we stop and we just say, yep, it's an adjustment disorder, then we're not going to be providing the best treatment experience that we can. And then sometimes it can actually be harmful in a way. We're not really kind of getting to the root cause of things and identifying this. So making sure whether it's in the intake, we're asking follow-up questions, or even after an intake session, we're kind of checking to ensure that, okay, is this truly an adjustment disorder, or is there something more here? And that we're really kind of having a discerning eye there.
Yeah. And I think for me, a little different take, but it was a comment that you had, or I guess a question you had asked about kind of, I guess, co-occurrence of one disorder and then an adjustment disorder. And while we may not diagnose that as two separate disorders, I think we can't forget the relevance that we see somebody that maybe has a generalized anxiety disorder, but a stressor in their life creates a higher level of adjustment. And we do have to treat that like an adjustment disorder. Like it's, we can't just keep sticking to treating the underlying anxiety or depression or whatever we're dealing with. Mental health is just such a moving target sometimes,
Nebulous. Yeah,
it is. And it's, so being able to, I think, just recognize that. And again, maybe that's a little off of the fact of diagnosing, but something we have to absolutely keep in mind and make those shifts as we're going through treatment. And, for those of you listening, as always, would love to hear your thoughts about, anything related to adjustment disorders. Join us on social media or message us. We'd love to hear from you.
With that, we hope you enjoy this practice in action episode. So you mean everyone doesn't have an adjustment disorder?
Well, Paul, today we're going to take a little jump off of our episode when we were talking about adjustment and maybe now go into more of a clinical mode today.
I like it.
Yeah. So, we're going to, I guess, focus on adjustment disorders.
Yeah. And, something that, especially early on in my career, I just didn't really know what it was. Like it was something that I think it was kind of framed as like, oh, hey, it's the billing code that you can kind of put for everyone. And,
right.
at the time, I know I've used adjustment disorder too much early on, but really trying to be discerning, now. And I think that, hopefully that's the trend. Whereas clinicians are becoming more and more experienced in the field, we're deviating away from this overdiagnosis of adjustment disorder. But I think a really important part is, what even is it? Like that idea.
Yeah, I think that's a great place to start, because I don't want to minimize the fact that adjustment disorders are real. They're out there, and there's many times that they are the most appropriate diagnosis. And I think your experience is kind of similar to mine, and probably, I don't know, I bet you most clinicians listening, early in our career, we're afraid of misdiagnosis. And so we go with what we think is the lesser of the problems. And while I think on paper, maybe that's okay, sometimes by misdiagnosis, my concern is always that we end up maybe going down the wrong treatment path with certain people and not recognizing that the problems, if we diagnose right, we'll get a more appropriate kind of treatment plan for them to follow. So let's talk about what an adjustment disorder is.
Yeah. So the episode that really kind of sparked this conversation was talking about life stressors. And, I think life stressors are really a breeding ground of adjustment disorder. That's not to say that every life stressor comes along with an adjustment disorder, though, but it's really, at least my conceptualization of it now is like, it's something that it takes those experiences and it starts to bleed over into other areas. So we're starting to see, if there's, familial concerns, we're starting to then see, the symptom being more intensive and, occurring, at work and occurring in friendships, occurring like all these different, more diverse areas. So, when I'm feeling overwhelmed and I can't do anything about this, and there's a very specific and targeted reason why. At least that's kind of my conceptualization for it.
Yeah, I agree. I think that's exactly it. I mean, we have a pronounced stressor and it creates symptoms, but those symptoms occur outside of just when that stressor is present. So, a child whose family is going through or parents are going through a divorce, and we're seeing an uptick of behaviors at school, whether that be anxiety or depression. The symptoms I think can go throughout the day, but they start because of the stressor and are generally in excess of the stressor. So, I mean, it's beyond what we would expect the behaviors to be.
And I like that in excess, or like the word that really like disproportionate, like as well.
Yeah, right.
So like when we're talking about like that anxiety and the impact, like it can almost, wow, we're really now struggling in school because of this event that's going on. And it's not to minimize the event, but it's saying that if we're looking at the impact of this event where it should have, and the areas where we should be seeing this, we're noticing that it goes above and beyond.
Yeah. And I mean, I look at it even with, as we said in our last episode, when we were talking about adjustments in general, is sometimes the reaction is appropriate. Like, if again, we'll use maybe the divorce situation, if a child's parents are getting divorced and they're anxious about what's going to happen, that's normal, right? Yeah. I mean, and that doesn't mean they don't need help, but is that to a point that it's a disorder? Maybe or maybe not. I mean, I think we can't just jump to that. But when it's in excess and we're seeing now that maybe it's not just that they're anxious about which house they're going to live in, but now they won't separate and go to school, then we see that functional impairment and that excess. And I think we always have to keep that in mind. Yeah. And all disorders, we should have an impairment that kind of comes with it. So on the other end of that, though, I think the thing that maybe kind of we started with is we overuse adjustment disorders. I think sometimes because we think they're safe and it minimizes us from maybe someone has depression or that they have a generalized anxiety disorder. And so we go with that lesser piece and we don't really do a good job of differentiating diagnosis. And, maybe to kind of go through this a little bit, let's maybe talk about the different types of adjustment disorders and maybe how we would differentiate with other disorders.
Yeah, no, I think that's really, it's, is it adjustment or is it something more? Yeah. And, you give a great example, right? Like talking about a bit of the cost as well of, if we are misdiagnosing. Mm-hmm. And so if we're identifying adjustment disorder with depressive presentation, and it's not just an adjustment disorder, but if if we are looking, truly at, major depressive disorder, then the way that we treat it is going to be different. And, do you actually mind sharing a bit of that story that you were talking about?
Yeah. I mean, so that, specifically an individual I had that I was got asked to do an evaluation, and the person's had an adjustment disorder with depressed mood for a little over a year now. And it was initially prompted because he went to therapy because he was going through a divorce. And he was having depressive reactions. And, it ended up coming to me because the therapist said, despite us doing all this work and the divorce is still ongoing, but it's not as much of a stressor now, but still is there. And they said, he's not progressing. He's still kind of where it's at. We're in the same place he was in the beginning. And so when we did the evaluation, one of the first things that, I did was talk a little bit about that situation. Yeah, he's getting divorced, and what are the situations he's having with his mood. But as we started digging deeper, and I went back and said, so when was the first time you've ever felt depressed? And he's like, oh, I was depressed when I was a kid. I was 8 years old and I remember getting depressed. And, then we start talking further, and there's this pattern that develops. He's had depression throughout his life, but it was mild, so it was manageable. He would maybe go into a depressive episode and, maybe he'd feel sluggish or sad or maybe fatigued, maybe tearful at times, irritable at times, but it was always something he could get through. The divorce created a stressor that made that depressive episode more severe. But what was important is that, he doesn't have an adjustment disorder. He truly has a major depressive disorder, and that was mild through his life and manageable through many just good coping skills that this guy had. And all of a sudden, his coping skills couldn't handle the stressor, and the depression became more severe. And so through this, one of the things we talked about was, maybe in addition to therapy, we needed to explore medication. And he was like, well, because I have an adjustment disorder, my doctor said he won't prescribe medication. And, that's where I think this idea of not looking further created a problem for this guy. And so instead I said, listen, I think you have a major depressive disorder. Here's why. And we talked through it, talked with his PCP, and, had him start on a SSRI mild dose. And now we're able to kind of move a little bit further with his actual treatment of his depression, and not just talking about divorce. Now, talking about the fact that you've dealt with negative thought patterns your whole life. You've just been able to get yourself out of them, or they weren't as severe. And now we have to just deal with those different. So we've changed this whole treatment approach by just diving a little deeper.
Yeah. And I think that is just such an important piece because, we're trying to provide accurate and supportive treatment. And, the diagnosis can be such a driving force there. Mm-hmm. And so when we're thinking about adjustment disorder, I think it's important to also then look at, what is the history or even the family history piece of that? And also, is this the initial onset of of an anxiety disorder or a mood disorder? And almost that there has to be that specificity tied in with whether it's a singular event or, multiple events that are the driving factor, and, really ensuring that we're not just taking the easy, the easy road of, oh, this is the first thing that I'm seeing. So, we just stop there and we don't look beyond it.
Yeah, I think that's the key. And I think it's easy when someone comes in and they're during their intake, you say, so tell me about what got you to come into therapy today. And they give you this very specific event. I'm going through a divorce, and because I'm going through a divorce, I'm feeling depressed. And that's true. I think it's, we got to take that at face value. But I think in the case I was just mentioning, I think the mistake that happened from the therapist was they stopped there. And it became a conversation then about the divorce, and really taking that step back and going, okay, let's look at these patterns and let's look at how that's developed over time. I think also, to your point though, is an adjustment disorder can kick off the onset of something else. And I think people throughout their training may have heard the idea of a diathesis stress, or the diathesis stress model. The idea that we're predisposed, the diathesis piece is we're predisposed for certain disorders. We all have our biological makeup and our genetics and all of those things that give us, these things that could happen. And the stressor can onset those symptoms. So, even in the case, again, this gentleman, let's say he didn't even have any depression throughout his early life. But we look at family history, and his family history is actually pretty rampant for depression. But a year into it, we need to start questioning, hey, did we just have this as the event that kicked in a major depressive disorder? And if I took away his history and I looked at just the fact of what's happened over the past year for him, there are these reoccurrent depressive episodes that are, they last for 2 or 3 weeks. And he's like, and I feel really good. The interesting part for him is his depressive symptoms and some of the things around his divorce started overlapping. So, he would, around the time that he and his wife were going through negotiations for financial things, he went into a depressive episode. The interesting part was when I actually started breaking it down and saying, I want you to let's really break down, when did the depression start? His depression actually started several days before the actual meeting with his wife, but he attributed it to the fact of, I went into this financial discussion, and that's what kicked it off. But when we looked back and started tracking his mood and saying, listen, part of this is I need you to write stuff down. Let's talk about when they start. I want you, the first day you start feeling depressed, and let's rate your mood over several days to see what happens. We could see that pattern that happens. So we just have to do a little bit more investigation, I think.
Yeah. Well, and we're talking about depression. And so what if we just kind of stay there and talking about depressive disorders versus adjustment disorder with depressive presentation? And, I think we've kind of covering, what it can look like when we're misdiagnosing adjustment disorder with depressed presentation. What are the markers that you look for adjustment disorder, depressed presentation?
Yeah. So, it's kind of interesting, but most often when I see that it's really adjustment disorder, it's a much more level pattern than we see with recurrent depression.
Mm-hmm.
So, you got to think of depression as being episodic. We're going to see this kind of up and down. And with adjustment disorder, I think it almost presents more as a stress, a continual kind of stress that they have. Now, you can think of, could that be a persistent depressive disorder or something? But, unlikely, because, we need a year before we're going to see that. And we're going to see that low grade mood. Now, I will say there are times I've seen people who had an adjustment disorder, and then when we track backwards, they've probably had this low grade depression for many years. And again, they got through life. The stressor kind of kicked it off. I think with adjustment disorders, It looks like a stress reaction. The depression tends not to be as episodic.
Yeah.
It tends to be a constant tension that they're feeling. That doesn't mean it doesn't get worse at times, but it's clearly a different pattern. With major depressive disorder, when we really kind of, I think, talk through, we'll see almost, for the guy I was just mentioning, about every 2 months he'd go through these. So when we start tracking it, we start seeing a pretty clear pattern that develops. I think it looks different. I think it's those depressive experiences with adjustment disorder tend not to quite hit those depressive episode markers. So, maybe we're seeing like changes in appetite or maybe some sleep patterns, but it's different. It's just a different presentation overall. It might not be as severe. So, as much as I think DSM, there's things I don't like about DSM. I think if we really look at those criteria that make up a depressive episode, most of the time with adjustment disorder, you're not going to see all of those criteria met fully.
Yeah. And at least with the clients that I'm thinking of, it really feels like so closely tied into the events that, the adjustment disorder is relating to. And so, the immense relief when someone says like, oh, this is finally over, or, oh, this has happened. And, again, I think that can happen with depressive episodes, but it alleviates and it stays alleviated. And, we're continuing to talk about, again, to borrow from our previous episode, now that they're in this new norm that they have adjusted with, there is now kind of okay, I have a plan. I can kind of see what's going to happen here. And I'm feeling like I have, some more agency or control over my life, really seeing those symptoms fall off pretty quickly. And because it's not episodic or it doesn't kind of show in this kind of waveform, seeing a sharp decrease. And I think that's something I also look for, the sharp increase, sharp decrease, and that sustained piece in between.
Yeah. And I even go back to just, kind of theory itself. Think of Aaron Beck and the cognitive triad of depression, right? And it's, this idea that, this negative view of self, negative view of the world, and negative view of the future. And with depression, those things are much more, I think, more intense, and they're not as situationally specific. So, I've seen people with adjustment disorder that, maybe they're not feeling good about themselves in relationships if they're going through a divorce. But they still think they're good at their job. They still think maybe they're a good parent or whatever it might be. That negative view of self isn't so broad.
Yeah.
Where with depression, I think we see that crossing many spheres of life. And even with the future, maybe somebody going through a divorce is going, I'm never going to find anybody. And there is that negative view of future, but it's not like I'm going to fail at everything. So I think that's the other way when we look at asking the right questions with adjustment disorders, we're not going to see those three spheres being so global, where it's much more specific to certain aspects.
Absolutely. Well, and talking about depression, and I think depression has the comparative nature of episodic versus sustained. What are your thoughts on like anxiety disorders comparatively to adjustment disorder with anxious presentation? And I feel that those have a lot more parallels in some ways. And that differentiating again, I think is, how global is it? What are the ways that, it's interfering, the areas that it's interfering, but those thought patterns, though, I think can be activated a bit more intensely with anxiety or adjustment disorder with anxious presentation, at least in my experience. What are your thoughts?
I agree. I mean, I think that going back to that idea, is the worry and the anxiety just specific to that situation? And it's interesting. I mean, I think I don't want to minimize the fact that, if there's a major life event for somebody, it can cross spheres. So it can be, where their anxiety, and I don't know why I'm stuck on divorce right now, but that's what's in my head. But they might, maybe they're anxious about meeting new people. They're anxious about living alone. They're anxious how they're going to financially survive on their own. Like their anxiety might cross a whole bunch of levels. But the worry is all connected back to the stressor. And I think that's when we think of adjustment disorders, it always connects back. So it can be multiple things, but it's, again, we can tie it back to that thing. That's different than generalized anxiety disorder, where there's no tie back. It truly is general. Like it's, those different areas, they almost are each independent. That helps me differentiate when I think about anxiety. The one that's, I think, the hardest is, I think, at least in my experience, anxiety with an adjustment disorder with anxiety and anxiety disorders, the physical symptoms are hard to differentiate.
Oh, yeah,
jitteriness is jitteriness.
Yeah.
And it can happen at odd times. I've had somebody who truly did have an adjustment disorder, but they were having these kind of subclinical panic type symptoms, but they were happening all over the map. Like there was no consistency. And even at times when this individual was not thinking about the stressor, they were just randomly coming up. So I would say those, at least in my experience, those are harder to use as a differentiator. They kind of look the same, but the thoughts we can always tie back to the stressor.
And that's where, like, when you were talking, even with the individual about the depression, but like the mapping piece of it, and
map, it's a good word.
Being able to, we're going to find the root cause, or we're going to find, what is this core area, and if it's tied in with a certain event or events that are going on, okay, it's adjustment disorder. I find that, and this doesn't happen very often, but when it's the initial onset for something like generalized anxiety disorder, that's a bit more challenging. And I think, that's where it's continuing to evaluate and continuing to update. And, if we're starting to see initially going back to this root cause, but now we're starting to deviate, and we're starting to see these pervasive thought patterns starting to expand that has nothing to do with it. And it's not even related to this. We're just seeing the presentation grow.
Right.
I think that's where, again, trying to differentiate between, okay, is this a point where we're maybe talking about medication and looking at other treatment options versus some of the more like skill building aspects or stress management, stress relief that we typically look with adjustment disorder.
Yeah. I mean, I think all of this goes back to a much earlier episode when we talked about case conceptualization and the idea that, we're always making hypotheses in diagnosis and in conceptualization in general. And we do have to keep revisiting it. I mean, I think the very biggest problem clinically is that we think we're right with the diagnosis from the start. And maybe we should have started with this, but I think the idea that, okay, maybe after one session of an intake, maybe adjustment disorder is the best that we got. That may just be where it's at. And that's not a problem. Like, I would rather see somebody do that and not misdiagnose in the other direction, maybe something more significant. But I think we owe it to our patients and to ourselves clinically that we can't end there. Like, so maybe it's recurrent. Like my process is every 4 sessions. And I don't know where I got that number. I don't, maybe I read it somewhere. I don't know, or somebody told me that. But every 4 sessions, as I'm doing my notes, I think, is this right? Is this the right diagnosis? Are we on the right track? And I think if we kind of use that, a kind of a consistent timeline, I think that lends us to always staying sharp with diagnosis. So maybe we do start an adjustment disorder, but 4 sessions in, I know that person better. I'm going to hear patterns that are different. Maybe, something in therapy takes us down a different path. And going back to your word, we can start mapping things differently. And so I think adjustment disorders, if it's safe at the beginning, that's okay. But let's make sure we're double checking ourselves.
And I think really that's a lot of the value of like talking about these rule out diagnosis, and whether it's, if our EMR allows us to actually mark it down as a rule out or not, or if we just need to keep it in mind. But, even the DSM, that those sections right after, talking about the diagnostic criteria, it's talking about ruling out, making sure that there's no other diagnosis that has a better fit. And so just the value and importance of keeping that in mind. And again, just not stopping at that initial point.
Yeah. And I think that, again, it leads us down to a better, more effective treatment path sometimes. Maybe before we kind of talk about treatment, let's kind of throw in one more of the adjustment disorders. Now, I don't know if we have to talk about the unspecified and other specified part, but the other adjustment disorder that we have kind of listed in DSM is with mixed disturbance of emotion and conduct, which I kind of find maybe the most confusing. I don't know about you, but
absolutely, it was one in my early early days with treatment where just trying to avoid it because I didn't necessarily understand it all that well. And I don't know that I've necessarily had too many trainings or really had a lot of clarification. And I think it came through more experience. But you actually said something earlier that I think just really fits well, which is if we're thinking about that word and term conduct, it's kind of presents as ODD, but it's not as prevalent or not as consistent with ODD. And like that, I feel either vindictive at times or almost like a justice, like this isn't fair. This isn't just. And so but it's, and having those intense, either emotional, verbal or physical responses to people around them. And I think that's a helpful way of framing mixed disturbance of emotion and conduct, because I do think it's one that doesn't really get identified or talked about all that often.
Yeah. And I mean, I think sometimes we don't realize how severe that disturbance of conduct can be. And, I've seen kids that, they violate the rights of others. They do destructive behaviors. It almost even beyond the oppositional defiant piece, maybe even looks a little conduct disordered at times. But again, pattern of responses. When did it start? Do we see this quick onset that happens after something we can identify? Or is this something that gradually builds? It's so, again, differentiation. I had, thinking back over the summer, an evaluation that I was working with a young child, and came in initially, and they're like, well, he's going through a lot of stress. Grandmother died, and clear stressors in this kid's life. Easily could have said it was an adjustment disorder, and probably wouldn't have been wrong. Like, to be honest, I mean, it was there. But what was important when I started going back, I'm like, so when did this start? And they're like, oh, when he was 2. We started seeing some of these things, and we started again, kind of looking at this timeline. And yes, all of it got significantly worse to the point that they now were in therapy. But this was a kid that 5 years earlier was having temper tantrums that lasted an hour. But mom and dad truly have incredible patience and I think some really good behavioral skills that they were trying to implement, and they managed it. But now it got that they couldn't manage it because now we added a whole other level of intensity because of some of the stressors that happened in a pretty short period of time. I went back and went, I think this is probably an oppositional defiance that onsetted early. And not that we in treatment won't help this young guy with some adjustment to the stressors and grief and things that he's going through, but doing that without some new behavioral management for parents probably wouldn't get us as far as we would. So again, looking back, seeing when it started developing.
Ray, I'm curious as you're sharing that. Like, I'm thinking of a client who actually I also saw back over the summer who, there's a clear history of anxiety and depression for him. But when there are specific events that exacerbate things, can we have both, depression, anxiety, and adjustment disorder? And I'm thinking more of that conduct piece, because it's only in this specific situation where we saw the conduct in relation to a very specific event. And the diagnostic, value of that and recognizing how it might be an outlier versus not necessarily something that we have to build into the entire treatment process and overhaul everything, but recognizing, okay, this is something that's different. We're going to treat it as something different. What are your thoughts on that? I'm going to take the simple and easy way out of this and say DSM does a pretty good job of telling us which disorders adjustment disorder can co-occur with and which ones can't. But the more, thoughtful answer, other than deferring to DSM, is maybe we don't call it an adjustment disorder. Yeah. Maybe we do, maybe we don't. But if somebody has major depressive disorder and it exacerbates because of the adjustment, just adding an adjustment disorder doesn't help our treatment at all. Yeah. So I probably would say no. That's not a case that would make any sense. But that's why we have Z codes. It's why we have, so clearly it's clinically relevant enough that we should put it as part of our treatment plan. We should say, they're grieving the death of a family member or a divorce or losing a job, whatever that might be. It's still going to be clinically relevant, and that we help them with the adjustment process in addition to treating the underlying depression. And so, and I know there's probably people out there going, it doesn't really matter. You don't have to do it. But I always say it does. I always treatment plan and diagnose like I'm not going to be able to come into work tomorrow and maybe never work again. And can the next therapist read what I wrote and know what's happening enough that they can continue that treatment without missing a beat? And I think adding those things as part of our clinical picture, whether we call it an adjustment disorder or not, I think less relevant if there's other things going on, but at least putting them so that people can look at it and go, okay, we have to address two things here. We're treating depression and their adjustment to certain stressors in their life, and the treatment can co-occur. And the reason I wanted to bring this up is because the impact of, and actually this individual, he assumed the other way of, this is now what my depression looks like. And this is what this is now. And, it certainly exacerbated the depression, but, there's this, I'm going to run away. I'm going to, break in, I'm going to steal my keys and I'm going to drive off. And, like that, this kind of really intense mentality that really hasn't been present. Like there is no history for that. And we then, a session or two afterwards, he's sitting in my office in tears and he said, what's wrong with me? There has to be something wrong with me. Like, I should not feel this way. And we're trying to differentiate between, okay, we know what depression is. We know what anxiety is. This is something that's going above that. And I think I used the term, I don't even know that I said adjustment disorder, but hey, we're adjusting to what's going on. And the value of kind of identifying those additional symptoms as outliers and not the norm. And I think that diagnostically for him, it helped to give a greater sense of like, okay, I don't like where I'm at right now, but I know that that's not going to be forever either. And that's, I think, and
I think that's a great way to explain it. And whether it's permissible to diagnose it together or whatever word we want to use there, I think an explanation to individuals, man, it helps conceptualize it well for them. And to say that, man, I think that's the unique thing about mental health. It's one of those things where for all of us, we could be doing really great today and an event can happen and we're not doing really well tomorrow. And, it's, whether we call it adjustment, whatever we call it, we're all vulnerable to the impact of things. And I think for patients who already have some vulnerabilities because of other diagnoses, that it's more severe, maybe like the case you have, and being able to help them understand that here's your depression in one box, and in this other box is these stressors, and we're now like compounding them together. They're stacked on top of each other. And we have to work on the stressors. And then you're going to have what that baseline depression might be. It's still there and we're still treating that. But for the moment, we might have to go off course. I mean, and I think that's okay. And and not only okay, I think that's maybe what we have to do sometimes. If somebody's, I think being a young therapist, I was so rigid in going, okay, if I'm treating the depression, somebody comes in with something else and maybe we touch on it, but then I wanted to get back to this treatment of depression. Yeah. And I think my maturity clinically has been, okay, like, yes, we're always going to go back to that main treatment, but sometimes we just have to deal with what's in the room at the time. Yeah. And that's okay. And I think not only okay, it's even good for people. And, but yeah, I think those things can occur. And it's what I hate about diagnosis, is that, sometimes we try to put things in these nice, neat packages. It just doesn't work like that. It's helpful for good diagnosis because then it helps us give that base treatment, but there's always things we're going to be moving around. So let's, maybe since we're talking about the treatment piece here a little bit, maybe let's end with, so let's say it is an adjustment disorder. What are the treatments that are going to be the most, useful or effective to help people out?
Well, and I think going, with the nature of like the adjustment disorder is tied in with these particular, again, events or experiences that are going on. So what do we then need to do to support individuals with that? And I like, if we're oversimplifying it down to skill building, improving relaxation techniques or improving stress management techniques and improving support systems. And like, I think there's a variety of different approaches that do those things very well. But I think we need to really kind of key into what is the specific presentation of this adjustment disorder? What is that root cause? And is it something that's going to be, resolved by skill building? Mm-hmm. For some things, absolutely. For other things, no, it's not a skill deficit. It's environmental that's going on. Right. So that's where support and stress management is going to be much more valuable. So I think we need to kind of be aware because the treatment's going to fluctuate. But those are the three core areas that I really look for. Yeah,
I agree. And, and we've, I think, talked about a lot of these in past episodes. I think most research would show, things like cognitive behavior therapy, solution focused therapy, even interpersonal therapies do have some good research to help with these issues. Are others that you've thought of with
I feel like John Murphy has a ton of airtime. If you haven't listened to it yet, go back and listen to our John Murphy episode on solution focused therapy. But I still think it's one of the best approaches in working with adjustment disorder and working on identifying those specific areas and, how do we work to use the natural environment and also the skills that we already have and expanding upon them to be successful in resolving some of these areas.
And I think I'm just going to kind of add to that. I think, as we spent most of this episode talking about differentiating diagnosis, I think when we start with that solution focused approach with somebody, especially that we're thinking is an adjustment disorder, for the most part, we're going to see pretty good progress. And mainly because we're really meeting people where they're at with that approach. And so that doesn't mean that all their symptoms go away, but we're going to see some relief rather quick. At least that's been my experience. And when we don't, that's going to raise our red flags of, oh, maybe there's something more. So I agree. For me, that's usually my first starting point is doing some solution focused work.
And maybe I maybe misspoke earlier because that idea of skill building, I think solution focused does a great job of also talking about how do we skill build in improving our skill with relaxation or improving our stress management, improving our utilization or formulation of support systems. And so, and I think CBT does that too, but I think solution focus, that's what it's all about is, it's what is the solution? And even if there isn't necessarily a skill deficit because of the adjustment disorder, the solution still is a part of, how do we then get to the other side, like around this bend?
Yeah. I think the other piece that we didn't mention yet is, for some cases, I think family therapy is really the way to go. Couples therapy in some cases. I think that, goes back to that idea of support. Are there things that we need to kind of work with, kind of a larger support network? And, again, research wise, we see that as being effective therapy. I don't do much couples and family work myself, but, many times that's the direction I'm referring people to when they need to go, when there's something around, especially if it's maybe, a child whose parents are getting divorced, trying, not always easy, but trying to get everybody to work together is a good outcome usually.
And I think even expanding upon, depending on, again, the thing that's being adjusted to, I think there's specific support groups that are out there. Certainly, like Al-Anon, like things like that, or even I know that I think even in some of our local districts, there's group work with children who are currently going through divorce and things of that nature. So not only support in the family, but also support in terms of the peer integration and peer just kind of validation in a way.
Yeah, I'll tell you that. I'm glad you mentioned that. I mean, I sometimes always forget about, sometimes we get so focused on what we do as clinicians and don't realize how those peer support groups are so therapeutic for people. And there are a lot. I mean, it's, we could never even hit all of them. I mean, if you Google them, you'll find many. But I mean, I just think about my work when I've worked in more medical settings and, we had, caregiver support groups of, family members who maybe their parents or someone in their family was diagnosed with dementia, to a diabetes support group for dealing with, onset of type 2 diabetes. The list goes on. And yeah, I mean, what a valuable, resource, I think, for people that sometimes gets overlooked. And I think sometimes that's uncomfortable for people, being vulnerable and going to those types of groups. But my experience is people who embrace that, if it truly is an adjustment they're working through, I don't want to put myself out of business, but sometimes I think that's even more valuable than what I can do in a therapy room, because they truly all are able to help each other with the process that they're going through. And just that idea that you're not alone, it just carries so much value, I think, for people. So yeah, I'm glad you mentioned, I think support groups, we need to use them more, especially as it's so hard to get into therapy sometimes.
Yes. And maybe one last thing here when we're talking about, treatment approaches, and almost maybe treatment approaches that we shouldn't be using or shouldn't be pushing for. The one that really comes to mind is medication. If this is a true adjustment disorder, I don't know that medication is the option that we should be, or the avenue we should be pushing our clients towards, because these medications are designed, for these specific disorders that have this reoccurring or this prevalent, imbalance neurochemically, and that's just not what's occurring for an adjustment disorder.
Yeah, and I think research supports that pretty heavily, that we don't see good outcomes. Unfortunately, I think that I think sometimes they're used inappropriately because it can be maybe not a quick fix, but a quick relief. I tell a story often that years ago, my grandmother died, and the day that I was going to go to, or I guess the the morning after I found out she died, I had to go to urgent care for something, and just happened to mention something about it. It's not why I was in urgent care. I was in there for another reason. And the person there said, hey, let me write you a prescription for some Xanax to, you're going to have a few really difficult days. And, if you're stressed out, and I'm like, I'm okay. I mean, my grandmother was a wonderful woman, but she was in her 90s. This wasn't a unexpected thing. But I walked out of there going, wow, how surprising it was that a typical grief reaction that we should go through. We should appreciate the fact that we grieve people in our life. I mean, I don't think that's a bad thing. Crying's wonderful. Being sad's okay. But she wanted to take my pain away of my adjustment. And I kind of went like, wow, like I don't know that I think that's a good thing. And, I often tell patients that I'm like, listen, it would relieve it. You could probably take medication and it would numb some of the feelings, but it doesn't take away the fact that you're going through an adjustment. And maybe that's something down the line we have to get to for certain people. But I think there's a value in letting ourselves experience bad events. I'm just, I think we don't want to do that, but I don't know. If it doesn't kill you, it makes you stronger. That whole idea. I think that we need to feel emotions, and the best adjustment advice is let yourself adjust. Let yourself experience it. And if you're going through something bad, it's okay. Cry, feel sad. Let's get through that first, and then maybe if we need something down the line, that something can be discussed. But my experience is it never works for those that try it first. It's really the therapy and the support that's going to help people get through most often.
And it's what gives those experiences significance. And I'm reminded, and I can't remember the training that I heard this in, but the idea of, if we're going to live a large and fulfilling life, then we need to experience discomfort. Yeah. And if we're not, then we're not living a life.
I have to agree. And I think that's a great way to end this episode. So I think I'm glad we kind of talked through this. And, I think it's an area we don't get a lot of training in, but maybe a really valuable area. So
it absolutely is. So, and we hope you tune in next week. But until then, be well, stay psyched. The information contained in this podcast and on the Psyched to Practice website is intended for informational and educational purposes only. Nothing in this podcast or on the website is intended to be a substitute for professional, psychological, psychiatric, educational, or medical advice, diagnosis, or treatment. Please note that no professional patient relationship is formed here, and similarly, no supervisory or consultative relationship is formed between the host, guests, and listeners of this podcast. If you need the qualified advice of a mental health professional or practitioner, please contact services in your area. Similarly, if you need supervision on clinical matters, please locate a supervisor with experience to fit your professional needs.